Thanks, and welcome everyone to Breakfast with the Chiefs today. I really don't know if it's necessary to introduce our Deputy Minister, Bob Bell. Really grateful to Bob for taking the time to share his wisdom and thoughts for where the healthcare system in Ontario is going. So the format for today is largely going to be, I think Bob has agreed to take some questions, but first he'll sort of spend 15 or so minutes sharing his thoughts. I'm going to try my best to channel my inner Matt Galloway and ask some of the tough questions. And what I'd really like actually is help from folks in the audience to ask the tough questions. So we'll probably do a little bit of questions from the audience, some questions from me, and some back and forth. But first, over to you, Bob.
Thanks so much, Irfan. Thank you for doing this, and thank you to Anton and Matthew for the invitation. There are some seats down the front here if folks want to move down. And it is part of the Sinai culture. I think, Joe, you can still sit in the rows coming down. Isn't that part? Joseph and Marian, you've done such a wonderful job on this hospital. I walked in here, wasn't sure where I was, having worked here for many years. Congratulations, Joe, on a beautiful job redeveloping Sinai. Just fabulous. And I was teasing Joe when I came in. Obviously, with the Sinai system merger, Bridgepoint set the standard, and Sinai had to catch up in terms of the look and the feel of the organization. So it's a real pleasure to be here, and I just introduced down front here my partner in crime, Nancy Naylor. Would you mind just waving, Nancy? Nancy, the Associate Deputy Minister of Health System Accountability and Performance. And today I serve as the mouthpiece, but the brains behind this is really Nancy and her team. And I just want to start off by saying, you know, I've been fortunate enough to practice in this province. Coming up, I don't think you call it an anniversary, but you note your 40th year of practice. I've had my license here, been a member of the OMA for 40 years as of July of this year. And I don't think I've ever been more excited about the opportunity that we have to make this system something that we can be extraordinarily proud of, something that we think is appropriate for our children and the folks that come beyond, and something that really can be world-leading in the way we organize care around the patient. I think we have such a remarkable opportunity. You know, the size of Ontario, 13.5 million people, about 50% bigger than Kaiser is probably about right. And some of the changes that I want to chat about briefly, I think represent the next step in a continuous evolution. The evolution doesn't stop. We recognize that as people who are committed to quality improvement. We know it's not going to stop. But I think what's about to happen is a substantive change in the framework that we work in that allows quality and allows patient service and allows a patient focus to be more prevalent in the way we plan the system. So I just want to talk a little bit about the discussion paper that Minister Hoskins released in December. I want to tell you that one of the things that's different right now is that we've all talked about change. We've all talked about system change. Everybody in this room has talked about it for the last 10 or 15 years. We know it's not a system. We know it doesn't work. We know that patients fall off cracks. We know that interfaces are not smooth. We've all talked about it. But we haven't had a minister who's courageous enough to do something about it. And this minister is. He's looked at the system. He's got the benefit of having a majority government behind him. He knows the system as a primary care provider, as a public health specialist. You know, he knows. He's worked in Ontario's system. And he has the courage to say, take a step, a bit into the unknown, a measured step, but a step that's actually creating substantial change. And he has the courage to do that. My sense on a daily basis, and I know Nancy's sense, is we can't let him down, right? He's given us the license to try to create something different, and it's important that we deliver on this, most important that we deliver for our patients. So let me tell you my view of why this change is so important, what it represents, and then I'll be really interested in your impressions. Nancy and I and our team are going around the provinces in Brampton last night, listening to 200 governors of health organizations, a lot of feedback, a lot of discussion. So we're very interested in listening to everybody. We're in a 2-month period of consultation, but obviously the consultation and the listening continues for the next year or more as these changes start to evolve and become implemented. So what's this change all about? Why is it appropriate in our view at this point in Ontario's healthcare history? And you know, if you look back to the turn of the millennium, Ontario was in a totally different position. When you talk to Ontarians at that time, they talked about a lack of trust in the Ontario healthcare system. You look back at the data that's archived in the ministry about patient surveys, telephone surveys that were undertaken. People said, I don't know, if I need heart surgery, if I need cancer surgery, if I need cancer radiation, I don't know if I'm going to be able to get it. It looks like waiting lists are long. My mother couldn't get her hip fixed for 2 years. My dad's been waiting for his cataract surgery. So people were concerned about services that were acute care services. And I think the investments that Ontario made in wait times, the change in performance measurement and management that occurred in the cancer system, and then under Excellent Care for All started rolling out across the acute care system, has had two impacts. It's improved our acute care systems measurably in terms of wait times, in terms of C. diff outbreaks, in terms of hospital standardized more. There's still more to do, no question, but I think anybody working in an acute care hospital would say it's a safer, better environment providing better service than it did 10 years ago. So that's one important improvement. The second thing is it's taught us an awful lot about how change occurs in Ontario and how you actually stimulate change, the kinds of issues around readiness assessment, around clinical engagement, around accurate performance measurement, setting achievable targets, measuring targets, holding people accountable for those sorts of elements that are standard change management practice have been successful in evolution and quality improvement in Ontario. The development of HQO, the legislation around ACFA, these are things that have moved the needle. Now it's time to move the needle, not just in acute care, but across our whole system. Because what we hear from Ontarians now is different. They don't talk about acute care. In fact, what they say is we think that the system's probably pretty good. And we understand that there are spheres of excellence within our system. We're delighted to have a primary care doctor because, as you know, 94% of people now report having a primary care doctor. But one of the things we hear over and over again in our surveys, and we hear from constituency, that's a term I didn't know, Joe, before the last day, there are constituency offices out there. And that's where politicians learn about what's, in the minds of their constituents about the healthcare system. And the thing they say is, delighted to have a family doctor, but gosh, it's hard to get in to see my family doctor. I call and I never get to see him when I'm sick or one of my kids is sick, and I end up going to a walk-in clinic or an emergency department because I can't. So that's one concern they have. They also have big concern about complexity, especially in community services, especially around home care, and especially around community mental health. So that's kind of the problem set that we're dealing with now, is the fact that there are excellent areas of service in the healthcare system, but it doesn't really work like a system. So what we described in the discussion paper brought out in December was really an enterprise model that is a regional health authority model, no question, with two critical differences from anything that's happened in Canada to this point. And it clearly establishes, unlike Alberta, which has a CEO of the Alberta health system, average job expectancy 14 months, something like that. Doesn't have, what it has an enterprise where the strategy, the direction of the health system is clearly at the direction of the Minister of Health. And subsequent to that is delegated, because in a province with this geographic geographic diversity, this cultural diversity, obviously you can't run a health system for 13.5 million people from Queen's Park. Authority for implementation of the minister's strategy and direction and the standardized outcomes that they want to achieve for the province is delegated to the LHINs. And our LHINs are 10 years old. Some people say, well, they don't have the strength to do it. Well, if they don't have the strength to do it, they need to strengthen. Because it's very clear we need a regional health authority model if we're going to offer a regional system that has coherence and is comprehensible to Ontarians. So the concept is that LHINs will represent a single point of accountability regionally for achieving the minister's direction, the strategy, and the standard consistent outcomes expected across the health system. Now, you can't plan a granular health system with primary care and home and community care for the 1.8 million people in the central Lynn. So the second piece of this is single point of accountability, but Lynn subregions, far more granular communities representing 75,000 people up to 250,000 people that will serve, we're calling them right now, the terrible title is Lynn subregions. Probably need to think of a better title than that eventually. But you know, they're built on health links. Realistically, health links, 90 health links across the province now, looking after 5% of a regional population defined by postal codes. This is simply expanding that health links population postal code approach out to 100% of the population from only 5% of the population. Health links will still exist, but we're simply overlapping in most of our LHINs that geographic context. So single point of accountability for a region, sub-regions developing their plans, and crucially, two elements that are different from other regional health authority models. Hospital boards will continue. Why? Because hospitals represent the most expensive, the most risky parts of the healthcare system. Ontario has established tremendous quality improvements in its hospitals through the volunteer governance of its hospital boards. Why would we mess with success? Hospital boards will continue. Hospitals will continue to be part of the LHIN funding envelope. But crucially, as the LHINs take on a new role, they will have responsibility for planning and the performance of primary care. And this is system based on, as we know all good health systems are, on a solid foundation of primary care. Operating under a variety of models that you know about, community health centers, nurse practitioner-led clinics, family health teams, the variety of models that exist across the system. Probably we need to strategize a little bit about the evolution of those models, but models of comprehensive primary care is the foundation that this new system will rely on. With the LHIN, doing the evaluation of health human resources in primary care across a region and a sub-region to say, hey, not only do we need 14 more primary care providers, but probably this area, Thorncliffe Park, needs a different kind of model of primary care delivery than the Rosedale neighborhood that also needs a couple of physicians added to its family health team. So you get the sense of where we're going. A solid foundation of primary care planned by the LHIN, and crucially, we need to start measuring the performance of the access, of the quality of care that Ontarians receive in primary care. How do you do that? How can you possibly measure I think the only way you can do it is by asking people. So a survey method for asking Ontarians, were you able to get an access to your primary care provider? Does your primary care provider describe to you how you get access nights and weekends to a primary care provider who may not be yours, but has access to your records, is part of the coverage group that your primary care provider is part of? You know, I mean, pretty standard stuff, but we have to find out from Ontarians how various primary care providers are performing across the province. So that's the second change. The third change is the crucial importance of home and community care. I use that term advisedly because right now there's home care run by the CCACs, and then there's community care, which is basically run by the LHINs, run by organizations that are funded by and report to the LHINs.